in a lot of conferences and
That's right.
courses. Mm.
Yeah. Yeah, you're right. So you want to test the screen share before I put everybody
Okay,
in
all
the
right.
chat.
Let me try. Hold on, yeah. Uh, okay. All right. Okay. Great.
Full screen?
I think should be okay. Yeah, I
Okay.
think should be okay.
Uh, I'll let you prepare for a few minutes while I open the session. Thank you.
All right. Okay.
sejawat sekalian pemirsa. Studium Generale dari Jakarta Musculoskeletal Focus Course. Dr. Cindy, can you hear me?
Yes, I can clearly.
Oh, yeah. Okay. Oh, sorry, I got confused. What happened?
Okay, totally
Suddenly,
understood.
suddenly my streaming is stopped.
All right.
So, baik, selamat sore hadirin sejawat sekalian, pemirsa Studium Generale yang ke-24 saat ini. Dari Jakarta Musculoskeletal Focus Course, kita ketemu lagi. Ini adalah sesi Studium Generale yang pertama di tahun 2026. Dan karena yang tahun kemarin kita mengakhiri dengan speaker tamu ya dari negara lain, dari Hong Kong. Nah, kali ini kita membuka 2026 dengan tamu juga dari negara tetangga. So, ini jadi di Malaysia, tepatnya di daerah negara bagian Sabah, kalau tidak salah. Di atasnya Kalimantan. Jadi sebenarnya ini masih satu pulau dengan negara kita ya. Jadi saya rasa tidak ada salahnya kita sekarang saling berbagi ilmu dan pengetahuan dalam hal muskuloskeletal dengan tetangga kita. Let me introduce to you Dr. Cindy Chin Yen Ling. She is head of department uh, uh, from the Department of Radiology di tempat kerja di Faculty of Medicine and Health Science di University Malaysia Sabah UMS. And she's also worked at the Hospital Queen Elizabeth at the Radiology Department there. And she focused on musculoskeletal imaging. And I met her in some MSK session before. And this afternoon, she will share to us about the pitfalls in osteoporosis. So, Dr. Cindy, are you
Yes,
ready?
thank you.
Welcome, and thank you to join us. And I let you start the
All
session.
right. Thank
Thank
you
you very
very
much.
much, Dr. Marcel, for the very nice introduction. Selamat sore, everyone. Good evening. So I'm Dr. Cindy. I'm the, like Dr. Marcel have introduced just now, I'm the head of radiology department in University Malaysia Sabah. And my special interest is in musculoskeletal radiology. So today, thank you very much for giving me the honor to be one of your speaker for your monthly online webinar. So the topic that I'll be sharing today is on common pitfalls in osteoporosis imaging. The reason why I'm picking this topic in particular is because osteoporosis topic is not something that is commonly talked about or shared on in a lot of conferences and courses. Okay, hold on, yeah. Let me just. All right. Can you see my shared slide?
Yes, nice
All
and
right.
clear.
Okay. Okay, nice. So, and also another thing about this osteoporotic fracture or insufficiency fracture is that it's largely underreported. And especially in Malaysia, it's not only it's largely underreported and it's not being reported correctly or properly. And although this, as time goes by, osteoporosis cases is actually have been increasing, but we didn't actually realize it, or we don't really see it until it actually happens, or until actually we found it on the X-ray and all. Even we found it on the X-ray, we kind of like somehow a lot of the times it slipped off our mind and we'll just report it as traumatic fracture instead of insufficiency fracture. And because of the misreporting, we actually kind of the patient have missed the osteoporotic management, which if we catch it and reported it correctly even in the first time, the patient would have started on the osteoporotic treatment or management, and it can actually avoid subsequent insufficiency fracture in later in life. All right. So hence that's why I choose this topic. Okay. All right. So pitfalls. I'll be sharing roughly around 8 pitfalls. Okay. In most of it, some are pitfalls, some are actually the things that we should ponder on when we actually look at osteoporotic fracture. Okay. All right. So please let me know if on and off my line wasn't good, you can't hear me, or actually my slide is not moving. I'm afraid I'm actually worried about my poor internet connection. All right. So basically, osteoporosis is one of the most common metabolic bone disease, and it's actually affect more than 200 million people worldwide. And how high is it? The prevalence is 1 in 4 women and 1 in 8 men in a patient age more than 65 years old. And this is expected to continue to increase, all right? And if we look at the modifiable risk factor, it includes the low calcium and low vitamin D diet, sedentary lifestyle, smoking, alcohol consumption, and underweight. So if we look at the modifiable risk factor, is actually what we will see among the current our patient population, our patient pool. So most nowadays people seldom actually go out anymore. It's more of a sedentary lifestyle, not really working out at all. And with all the convenience of ordering food, grab at the tips of our finger, dietary is it's basically it's out of the window. It's low calcium, low vitamin D, and a lot of the patient, if we realize our patient also, most of them, the number of smokers and also alcohol consumers have also increased. And in the era of social media, among teenagers, young adults, a lot are underweight as well. So it's undeniable osteoporosis is actually just increasing in prevalence, and it's actually a lot in our population. And also it's commonly associated or found in patients with rheumatoid arthritis, thyroid disease, chronic kidney or liver disease, patient on long-term steroids or anti-epileptic drugs. And also because it is so, I mean, osteoporosis is, since it is so common, but unfortunately most of them, 75% of patients with osteoporosis are asymptomatic. So they are only found when they complain of pain, or when they actually have a trivial kind of a trauma like slip and fall, or just a knock on something which is a very mild trauma, a very low force, low energy kind of trauma. And then when do x-ray, sustain pain, and then we do x-ray and noted, there's fracture. That's actually how we actually found it. Even when we found it, we will usually, most of the time, will just write it off as a vertebral fracture, hip fracture, any kind of bone fracture. But it's never came to the we never like actually reported it might due to an insufficiency fracture. And also vertebral, among all the types of fracture, vertebral fractures are the most common osteoporotic fractures. Okay. So the first pitfalls. The first thing is that the significance of insufficiency fracture. So fracture, there are 4 types. The first one, traumatic fracture. So basically traumatic fracture, as we all know, it's caused by a very high energy force of a trauma, a severe trauma force that applied to that is so severe that it exceeds what the bone can withstand. That is caused by a high traumatic fracture. Pathologic fracture is when there's a bone lesion. Okay, so when there's a bone lesion, it weakens. It causes the bone to have an abnormal architecture, and it weakens the bone strength. Then it leads to fracture, even with a very mild trauma. Okay, Stress fracture when the usually occur in athletes, okay? When even in a normal bone, when the normal bone it fractures, okay? Um, due to being exposed to this repetitive high stress, okay? And then comes to what we are talking about today, insufficiency fracture or fragility fracture. So it's fracture which is applied on a diffusely weakened bone, okay? A bone which is diffusely weakened, and even in a very low energy or mild trauma, or even there's no trauma, then suddenly you saw a fracture, okay? So most common most common cause of this insufficiency or fragility fracture is osteoporosis. But beside osteoporosis, there are also other less common causes which might cause this fragility or insufficiency fracture. Okay, so it can cause by osteogenesis imperfecta, a radiation osteonecrosis. Okay, and also it can be found among patients with chronic kidney disease, renal osteodystrophy, and osteomalacia. So in cases of insufficiency fracture, okay, we have to differentiate this osteoporotic from the other non-osteoporotic fragility or insufficiency fracture based on the clinical history, okay, and also their biochemical investigations. Okay, then the second pitfalls is to recognize the relationship, okay, is the relationship between the low bone density and insufficiency fracture. So of course, as bone density reduce, then then there's higher risk of fracture. And also we know that patients with osteoporosis have higher risk of fracture compared to those with osteopenia and normal bone density. But do you know that even in patient with in elderly patient, we're talking about elderly patient. We are not no need to compare between elderly and younger patients, because usually osteoporosis or osteopenia commonly found among patients in elderly patients. So if we compare, so in elderly patients, even if they have normal or osteopenic bone, not osteoporotic bone, they also can have this insufficiency fracture. They also can have this vertebral fracture. So it's because there's a lot, actually they did a research on this. Prof James Griffith, one of the very well-known musculoskeletal radiologists, they actually did a research on this. They found that because most of the elderly patients, they are in this osteopenic and normal bone group, normal bone density group, but still they have they can have this insufficiency fracture. So if you have a patient which did have a history, which have done a DEXA scan, noted its normal bone density, okay, or it's osteopenic, but you found that this patient have vertebral fracture, don't straight away rule this patient out as an insufficiency fracture, because even if the patient have a normal bone density, but if the patient tell you that, or the mechanism of injury, the patient actually slip and fall from a standing position, not from a very high impact trauma, a very trivial kind of fall, and there's a vertebral fracture, you have to think of osteoporotic fracture. Okay. Now, the third pitfall, it's important to know how to, not only how to report the vertebral fracture correctly, but firstly, we have to know how to recognize the osteoporotic fracture or vertebral fracture. Okay, in this case, we're taking vertebral fracture as the example, as vertebral fracture in a trivial kind of trauma. It's considered an osteoporotic fracture. Okay, so firstly, is when there's reduce in height. Okay, beside reduce in height, we also look at if there is any disruption or cortical break over the end plates, okay, and also if there's at the cortical margin. Okay, if there is a disruption at the end plates or the cortical margin, or which usually we'll see as a buckling like this. Okay, so that is the typical how the vertebral fracture pattern will be like. Okay, loss of height, disruption of end plate, and buckling. All right. Now, how to report? So when we report, how we report, we'll usually use like there is a compression fracture, or there is a compression fracture, or there is this reduce in height. We usually will just conclude it as a concave or compression fracture, compression vertebral fracture. Full stop. So by right, how we should report it is we should look at the reduction in height. Okay, so if the reduction in height is less than 20%, that is not considered as a fracture, provided we don't see cortical discontinuity. There's no cortical break over the end plates. There's no cortical discontinuity at the at the margin. Okay, at the cortex margin. Okay, and the only signs we see is that there is a reduce reduce vertebral body height. So because in vertebral body it's axial loading, so there will be physiologic wedging. All right, there will be physiologic reduce in the height because of wedging. Okay, axial loading. So if the reduction of the height is less than 20%, regardless it's anterior center of the posterior aspect of the vertebral body, it is still acceptable. That is considered physiologic. Okay, but if it's more than 20%, that is when we consider it as fracture. Okay, so oops. So then we have to divide it whether the reduction in height is at the anterior, center, or it's at the posterior aspect. Okay, after we have recognized which aspect is it reduced, then we have to subcategorize it into mild, moderate, severe. Mild is when the reduction in height is around 20 to 25%. Moderate when it's 25 to 40%. And severe when it's more than 40%. Why we have to go through all this trouble and categorize which severity it is? Because for severe vertebral fracture, we have to report that because in a patient, even though the patient have a normal bone density or osteopenia, not even osteoporosis bone density on DEXA scan, but once the vertebral fracture, okay, the osteoporotic vertebral fracture is grade 3, is a severe grade, means that the patient will develop multiple osteoporotic fracture in future. So this kind of patient should be catch early and started on osteoporotic treatment. Okay, then next we'll go to the fourth pitfall, which is something which is quite tricky to differentiate it from malignancy. Okay, because in osteoporotic fracture, because of this related, it's not well known, but some of it say that it's because of the poor bone perfusion. So as part of the healing process after fracture, they will have this severe exaggerated osteolysis. They will have this severe like osteolysis of the fracture bone, which I will show you, which you see on your screen right now. If you look at the pubic symphysis, the image pointed B, you will see this severe erosion or severe osteolysis. Okay, like a severe lytic changes over the right side of the pubic symphysis here. But if you look at it, the different pattern is, instead of showing it like a malignant kind of aggressive erosion, it's quite clean cut. The osteolysis in osteoporosis, although it's severe, it's exaggerated, but it's quite sharply demarcated or clean cut, like what you see in the image B. But for vertebral fracture, it's quite difficult to see, but it will have this on the vertebral fracture, there will be this vacuum phenomenon within the vertebral body itself. So that was mentioned as part of the severe osteolysis in osteoporotic fracture. But for a other bone other than the vertebral body, the osteolysis, the severe exaggerated osteolysis, it will leave a clean, sharp demarcation compared to an aggressive erosion of a malignant lesion. And I will show you another example. Here, if you look at the first image, the X-ray, you will see the femoral head disappear, and it leaves off the sharp demarcation of the intertrochanter. Okay, and another thing is that after the severe osteolysis, some of the cases will have this calcified, like sort of like a calcified lesion over the soft tissue. So these are actually the features of this pitfall, okay, whereby the severe osteolysis, it can be associated with or without this calcified kind of a soft tissue lesion. Okay, so it have exaggerated osteolysis with sharp demarcation, a kind of a clean cut, and then some of it is associated just adjacent to where the fracture is. There will be this calcified lesion. Okay, sort of like a calcified lesion. And so when there is an exaggerated osteolysis and exaggerated osteolysis, because of the same thing, poor perfusion also, poor compromised blood supply. So as part of the healing features. So basically, if you can see over the image here, over the fracture side, okay, adjacent to the fractured area, because of the poor blood flow, the compromised blood flow, it kind of give off the signal that it's not healed yet. So there will be more, over the time, there will be more and more callus formation being formed. But the rate of callus formation is even more than the usual. Okay, and because of this, a lot of us will confuse it as a sclerotic lesion, as a malignant aggressive kind of sclerotic lesion. So the problem comes when we try to biopsy this. So if we biopsy it, it will come back as a newborn formation because it's a callus. So, and when it's a newborn formation, it will be misinterpreted as osteosarcoma. So hence, before this kind of case is when, if we suspect, if the bone itself, generally it does look osteopenic, correlating with the mode of injury, which is either it's a trivial fall, it's a low energy fall, and then in such a short time, is such a short duration after the fall, there is this so much of callus form or exaggerated callus formation at the site of the fracture. We should think of, can this actually be an osteoporotic fracture instead of a malignant lesion? Okay. And for the next pitfall will be, since we're talking about the malignant lesion, we have to know how to differentiate between the osteoporotic and the malignant fracture, okay, or osteoporotic fracture from a malignant lesion. So by MRI wise, okay, so usually, as we know, malignant lesion usually, it mostly, theoretically speaking, it affects mostly the posterior column, the pedicles, the spinal process, okay. But in osteoporotic fracture, okay, it doesn't only, it can happen anyway, okay. It can occur at the anterior, central, and rarely at the posterior region, okay. And in malignancy, it will have associated with paraspinal masses, associated with paravertebral masses. while in osteoporotic and also in malignancy also, there will be more of an expansile at the posterior region. There will be an expansile kind of okay, let me show you. All right. So in the malignancy, you will see at the posterior region here, it will be more of an expansile growth posteriorly. Okay, which this lesion, it will have mass effect. Okay, onto the adjacent epidura. Okay, into and compressing onto the the adjacent cord, and also in malignancy also, beside compressing onto the adjacent cord, it will also be compressing, extend to the paravertebral or paraspinal spaces. But for a fracture, okay, hold on, yeah. Okay, so for a vertebral fracture, osteoporotic vertebral fracture, once it's fractured, the fracture part here will be retropulsed posteriorly. Okay, so if you look at here, so in the osteoporotic fracture, the posterior fracture fragment, it will be pushed posteriorly, retropulsed posteriorly, instead of it grow exponentially, okay, and grow exponentially and push to the back and cause compression to the adjacent cord. Okay, that's how to differentiate it. And also, in a vertebral fracture, in an osteoporotic fracture, if you do a CT, you will see the vertebral body. It it will be fractured in multiple fragments, no matter how bad it is. It will be in multiple fragments, but it doesn't show the aggressive erosion. Okay, you don't see aggressive erosion over the osteoporotic fracture. So it will have a multiple fragment, and this fragment will form like a puzzle-like pieces. Okay, in and also like I mentioned, for in malignancy, you will see the lesion is usually at affecting the posterior column, either the pedicle region, okay, or the spinous process. All right. And also another clue is that in a malignant fracture or in malignancy cases, you look at the bone marrow. Okay, usually in a malignant case, the fatty marrow edema will be either be absent or it will be rarely there. Okay, it's barely there. It's very minimal, barely there, or it's absent, totally absent. But in the osteoporotic fracture, the marrow edema is still preserved. Okay, at the area which is not affected by the fracture, it is still preserved compared to malignancy. All right. Okay. So, and also another thing is that in malignancy, there will be restricted diffusion. So, like the three lower images here, you can see in the DWI, it's diffusely raised in signal. And in ADC, there's a reduced signal, there's a restricted diffusion. And also in a T1, like I mentioned, the whole vertebral body, the normal fatty marrow in the whole vertebral body is gone. Okay. And if you compare with an osteoporotic case, the three upper image here, you can see in DWI, there's no increased signal. ADC, there's no reduced signal, there's no restricted diffusion. And in the, this is actually a T2, but it's quite too dark. So what I want to show you is that it's actually, there is preserved fatty marrow there. Okay. All right. Then the sixth pitfalls is the enhancement, contrast enhancement, regardless it's in MRI, CT, or PET scan. Unfortunately, in osteoporotic fracture, it shows enhancement, same like malignancy in both all these three. And it can, the enhancement is because of the newborn formation. It's not because of inflammatory or any abnormal cell, but because of the newborn formation, it enhances in all MRI, CT, PET scan. So how long can it enhance? There are articles say that it can go until 2 weeks post trauma itself. So if you're looking to compare by using contrast enhancement, that will be quite tricky. Okay. As you can see here in this osteoporotic, for osteoporotic fracture in post contrast, it enhances, and also the signal pick up on PET scan. Okay, and then the last one, this one is the misinterpretation of a DEXA result. So maybe before you maybe you look at the X-ray, CT, or MRI, you think, this case might be an osteoporotic fracture. So, and then you look at the patient's DEXA scan. So before you actually can, firstly, if for vertebral fracture, regardless of the DEXA result, whether it's osteoporosis, osteopenia, or normal bone density, if the trauma is actually a tribal trauma caused by a very low energy or mild trauma, it is still considered a osteoporotic fracture, okay, an insufficiency fracture. But if, let's say, the fracture occurs anywhere else other than vertebral body, then you have to correlate with how the trauma happens. Okay, if it's high trauma impact, then it can be traumatic. But if something that is trivial and also low energy, and also generally the bone does look osteopenic, then it can be osteoporotic. So when you look at DEXA, before you actually can accept whatever the result that's given to you, you have to see how is the DEXA scan done for that patient. It's because, let's say, the patient there are few factors which can influence or affect the result, okay, the bone density result. So in a patient who have scoliosis, it will give you the non-accurate result, because the patient in scoliosis patient, it will be rotated, okay. So the more the patient is rotated, okay, in a scoliosis, the more curvature, the more the vertebra is curved, the result will be it will abnormally increase, okay. Because when the vertebra is being it's curved, in the scoliosis case, more area is being captured, so hence the result will be falsely increased, and that happen for hip as well, okay. So in the hip, okay, so when the patient is actually rotated, okay, when you look at the DEXA image, when it's rotated, and the more we see the lesser trochanter, okay, it will actually give falsely increased result, okay, a falsely increased reading. And also we have to take into consideration the congenitally anatomical variation, because some patient may have 6 lumbar vertebra or a floating 12 rib. So all this will give a false result. And also, of course, if the patient have a metallic implant, or the plate screw, or even osteophyte sclerosis, okay, calcification, osteophytes, calcification, osteophytes, and all this will actually falsely increase the reading, okay. So these are the things which you have to look on, okay, before you actually accept the result, okay. So we have gone through the 8 pitfalls, or at least the 8 things we should ponder on when we are reading or looking at the osteoporotic fracture case. So now how about the other mimickers? So besides malignancy, there are also other mimickers which may cause us confuse it with osteoporotic fracture. So the first one will be the anterior vertebral vascular groove, okay. So if you look at if from if from the CT, either CT or X-ray, from sagittal view, you saw there is this linear, it looks like a linear loosened fracture line, okay, regardless in CT or in X-ray. So always compare it in coronal view. So if let's say in the sagittal view, it does look, you saw like a mimic of a fracture line, and if it still, you can still see it on a coronal view, then that is a real fracture line. If you compare it in a coronal view, you don't see it, that might be the vertebral vessel vein, sorry, the vertebral vein. Okay. And also congenitally in patient with mucopolysaccharidosis, in this condition, the patient will not only have kyphosis, but also will have a multiple hypoplastic vertebral body. Okay. And also patient with Schumann disease, whereby there will be multiple reduced vertebral body height, and also the end plate irregularities, and certain condition whereby there are vertebral plana, okay, like in this calf's disease. Okay. And all right, so that's the end of it. So before I end, a bit of a take home points. So insufficiency fracture, it's in elderly patient especially, it's not only happen in osteoporosis, patient with osteoporosis, but also it can happen in patients with osteopenic and as well as a normal bone density. Okay. And why it can happen so? Because it's not the low bone density, because the insufficiency fracture is not only caused by low bone density, it can also influence by how the bone architecture, the microarchitecture, macroarchitecture, the bone matrix, and also the bone matrix itself. So all these actually play an influence onto the risk of the insufficiency fracture. Okay. And also vertebral fracture is something that is underreported, like I mentioned, and it's largely missed that our CT or X-ray report for osteoporosis and categorize it as a mild, moderate, severe, because if it's severe, we can actually suggest the primary team to start off the osteoporosis management. And also be careful with the mimickers, which I've shared just now, like the vascular grooves, the mucopolysaccharidosis, and also don't only rely on contrast enhancement to rule out malignant, to differentiate between the osteoporotic fracture and also a malignant fracture. Yeah. So that's all. And these are my references. Something that is a bit short and sweet, since it's kind of like the end of the day talk for all of us. Yeah. Back to you, Dr. Marcel.
Thank you, Dr. Cindy, for the very interesting presentations. Uh, Before I forgot, for the audience, if you have any questions, please write your question in the chat box, and we will discuss it together. So don't be hesitant. So we're waiting for your question. So, Dr. Cindy, um, very nice presentation, and I would like to probably some of us here have the same, well, with what I have. One is about how to differentiate a fracture or osteoporosis in multiple myeloma cases. So as we know that in the multiple myeloma cases, usually the lesion is within the bone, but sometimes we have to problem to detect the lesion, especially if the patient is very, very old. So basically all the bone is already osteoporosis. Is there any way we can detect the lesion, especially involving the spine?
That is a very good
Do you
question.
have
Yeah.
any
All
thought on
right.
that?
So thank you for the question. That is a very good one. So basically, how if osteoporotic, the thing we have to understand osteoporotic fracture and multiple myeloma. Multiple myeloma, it doesn't only affect the spines, it affects everywhere, basically everywhere, right? But when osteoporotic fracture, the fracture occurs at the part where it's trauma, where trauma is being applied. So let's say the patient have a fall and then it's affecting, I mean, kind of like a slip and fall, okay? So it's fall on a sitting position, then the fracture we actually will kind of predict will be somewhere of the spine and maybe the hip, but it wouldn't be at the hand, at the upper limb, the skull, or the other parts of the lower limb. That is one where the trauma energy applies to. Secondly, in the if compared to multiple myeloma, it's multiple level. But osteoporotic fracture, it's rarely until it will maybe around 2 or 3 vertebrae, but it won't be the whole a long span of the spine itself, vertebral body. Yeah, and then besides that, also we correlate with the biochemical lah. So that's my suggestion to differentiate this multiple myeloma and also the osteoporotic fracture. But to totally differentiate it by imaging alone, it will be very hard to rule it out. But with that few condition that I mentioned just now, where the trauma applies, and also the whether it's a short span or it's a long extension of vertebra being involved, that is actually a hint where we can actually how we exclude it.
Okay, thank you. Another question. I have here some questions for you about the insufficiency fracture in how often do you find subchondral insufficiency fracture in an osteoarthritic knee joints, and how important it is? Is there any difference if we mention an insufficiency fracture in a degenerative knee?
Okay, so in a degenerative knee per se, if in Malaysia, okay, in osteoarthritis knee degenerative, frankly speaking, we don't find much of subchondral, I mean insufficiency subchondral fracture in a degenerative knee. Mostly, we actually find it in young patient actually. We don't find it in degenerative knee. So that is something which is quite interesting to see. But how important it is, okay. So I think because the management per se, it will actually if there's an insufficiency fracture in a degenerative knee in osteoarthritis, so of course it's important but to report it. But the severity because the severity that I mentioned just now is for vertebral fracture, the mild, moderate, severe. So there is vertebral fracture, because vertebral fracture, when it happens due to a mild trauma, it's considered straight away automatically it's osteoporotic fracture. But when the fracture, insufficiency fracture at other part of the body, that's when we have to be a bit careful whether it's a true insufficiency fracture or it's fracture because of trauma, pathological, or stress fracture. So I can't, because in here somehow osteoarthritis, I haven't found someone with osteoarthritis with insufficiency fracture. But as I say, if it's something which is very important to put in our report of this of our suspicion of this insufficiency fracture, because it will we can kickstart, or we can actually suggest the primary team to start off the osteoporosis management. the calcium supplement and what sort. Yeah. I hope that actually answers your question.
Okay, thank you very much for it. Yes. So, is there any question again from the audience? If I may ask. So far, okay, I think because of the presentation is very clear, so uh, hopefully it is useful for all of us because most of the time I agree that it is frequent misinterpretation or misdiagnosis, especially if we look for any other sign of insufficiency fracture in the uh, osteoporotic spine there. Probably one question, one more question, Dr. Cindy, because sometimes we have difficulties mm, to measure the severity of the fracture of the spine
Mm,
because in real cases, I don't know in your hospital, in my hospital, we frequently found that the patient is not properly positioned.
mm.
So the spine is very tilted to the other side. So it is a bit difficult for us to see which is the upper and lower end plate. So we can measure is how many percentage is the severity of the fracture. Do you have any tips how to overcome such problem?
Okay. So if it's actually because of patient positioning, then it caused the blur the end plates and all.
Mhm,
Because the okay, one thing maybe we can do is actually play around with the windowing. Either we
mhm,
adjust the brightness, we adjust the brightness.
mhm,
Another, and besides that, I don't think if anything much we can do because the image, the X-ray is already we already snap it in that un, improper kind of position. There's nothing much we can actually kind of cut and make it straight like that.
mm,
So in another article is that instead some they if it's because of positioning, I think the only thing I can suggest actually is the playing around with the windowing. But talking about this measuring the height, right? There is a lot of article. Yes, theoretically we should be measuring the end plates from the superior and the upper end plates to the inferior end plates. But there is also the one what Prof. James Griffith suggested is that is actually by grossly googling it. Meaning to say grossly googling it is we are taking the normal vertebral body, okay, like we're looking at the whole spine.
mhm,
We find the largest normal vertebral body height. That's how we comparison instead of like measuring it end plate to end plate. Yeah.
mm. So
Mm.
it means it will be more qualitative than quantitative, basically.
Yeah.
Oh,
Correct.
okay. Hmm. What's the name? Google grossing what? I don't know.
Oh, it's kind of like a grossly
Grossly
googling it, like yeah,
googling.
googling it, like seeing it in a big view instead of just one short point. So we look at
Oh, okay.
the
Look
whole
at the whole. Okay.
FOV, and then we look for
Right.
the most
Right.
normal and the biggest the vertebral body height. That's when we compare it grossly. Is it by half, 25%, or severe, moderate, or mild? Yeah, I
Mm,
think that can be applied for patient which is taken in an improper position as well.
mm.
Mm.
Okay. Okay. Thank you very much. Very interesting tips. So, if there is no other question from the audience, then I would like again to thank Dr. Cindy for sharing his spending time with us. And the afternoon, are you still at the office? No?
Oh no, no, I just yeah. Yeah, because we finish at
And
5. So yeah, so it's a good
wow.
timing actually.
Oh yes, good
Mm,
timing because we're neighbors, so the difference is not very, very far.
yeah,
Oh,
yeah.
or what?
It's a one
Thank you
hour
very much.
difference on it. Yeah.
1 hour
Mm,
difference,
yeah.
yes. So I believe that for those who did not know that Dr. Cindy also hosting her own musculoskeletal seminars usually, but the last year is already past. So which month do you usually do it?
Okay, because we actually do it every 3 monthly, and it's not only musculoskeletal. So it's a general. It's kind of
Oh,
rotation.
okay.
It can be musculoskeletal. We cover thorax, musculoskeletal, and we last December we have pediatric.
Mm,
So I'll keep you guys posted and will share with Dr. Marcel for our next we call it ICRE, International Continuous Radiology Education. So it's free
all
for
right.
all, something like this.
Mm-hmm. Mm-hmm.
But we are not focusing only on musculoskeletal, but basically in other subdiscipline as well. Yeah.
Yeah. So for those who are looking to look for other knowledge from our neighbors, and on the other hand, not very far from our country, and also jalan-jalan, uh, it's because it's not very far. So I believe that it will be very interesting to see in the future. So thank you again, personally. I hope you have a nice evening, and thank you very much for all the audience for come. We'll see again on some other
Thank
time.
you. Thank you,
Thank
Dr.
you very
Marcel. Thank you,
much.
everyone.
Take care. Thank you. Bye bye.